Welcome to Sleepy Nursing, the podcast where we break down nursing school stress into something you can actually fall asleep to. I'm Nick, for some of you, Mr. Forney, and I teach nursing students how to think critically, survive the chaos, and still get some rest. Whether you're cramming for exams or just need a calm voice with a stethoscope, you're in the right place. Tonight, I wanted to talk about the liver, gallbladder, and pancreas. So we're going to start with the gallbladder. When we think about the gallbladder, the terms we want to connect with that are cholecyst, basically. So when we're talking gallbladder, we think cholecyst. So removing the gallbladder is cholecystectomy. Stones in the gallbladder are cholelithiasis. Inflammation of the gallbladder is cholecystitis. Remember that cyst word brings us back to the bladder. We also think about that for like a cystoscopy or a cyst, like a fluid-filled sac. It goes back to a Greek word meaning fluid-filled sac, exactly. So if that's a way you can connect seeing cholecystitis on an exam with, I forgot what that's about, maybe the cyst. Oh yeah, that's got something to do with the bladder. So that's what we're talking about here. The first thing I want to talk about is cholelithiasis. So those are gallstones. They live inside the gallbladder, which, remember, the gallbladder is a sac that collects bile to basically squirt into the upper part of the intestines. When that gall kind of builds itself together, it becomes these ugly little stones that can block the bile duct and cause a lot of discomfort, but also a lot of digestive issues. So that's what we call when we have gallstones in the gallbladder. The other word for that is cholelithiasis. It's more likely to occur to people with a sedentary lifestyle. There are familial tendencies, diabetes, mellitus, and obesity can also contribute. Native Americans are also more prone to develop gallbladder stones than any other group. Hispanic Americans are the next group to follow. Cholecystitis, after that, is an inflammation of the gallbladder and is typically associated with gallstones in 90 to 95% of cases. Other causes can include obstructive tumors and severely stressful situations like cardiac surgery, burns, or multiple trauma. The symptoms are going to be right upper quadrant pain. Think about anatomically where the gallbladder is. You follow your esophagus down to your stomach, is kind of over on the left and moving over to the midline. Then it all connects up with the small intestines there at the duodenum, and that's where the gallbladder and the common bile duct empties into the intestines. So just medial to that is the gallbladder. And since those bile ducts lead down to the digestive tract, you can see where it moves over to the right upper quadrant. The pain may be triggered by a big fatty meal. Think about the things that would try and squeeze bile into the intestine to help digest food. It's being activated now and it's squeezing around these gallstones and it may be inflamed. So it makes sense that that's going to cause pain. You can see nausea and vomiting as well as fever, which makes sense with inflammation or infection a lot of the time, and leukocytosis with cholecystitis. The pain that's experienced may not only be in the right upper quadrant, it may radiate up to the right shoulder as well, and even down to the right arm. If the bile is allowed to back up into the liver, which the liver is the next stop, kind of more into the body from the gallbladder, you can see jaundice as that liver backs up and the bile backs up into the blood system. Jaundice, remember, is that yellow tint that is commonly seen in the skin, but in someone who's got a darker complexion, may be predominantly visible in the sclera around the eyes. There is also clay-colored stools you could expect. Why clay-colored stools? We're thinking about undigested fat content that's making it through the bowels. These clay-colored stools are also more likely to be very foul and floating. What do we do about it? Well, for diagnosis, we can expect a series of scans, kind of the scans you would expect. At the lower end of that, they can diagnose some of this through ultrasound, where they take a probe and put it on the outside of your body to send basically sound waves in and see what's happening inside your body. They can also send a patient for CT scan. They can do something called an ERCP, which you might have heard about in the hospital. That's an endoscopic retrograde cholangiopancreatography. If we break that word down, or that big term down, we remember endoscopic means we're putting a tube inside someone to look at stuff, a scope. Retrograde, I guess that goes towards the back or something, I'm not entirely sure. But then the cholangiopancreatography suggests all the organs involved. They can take a look at the colon, so the gallbladder, the pancreas as well, because those are very closely connected and they share that common bile duct. There are also HIDA scans they can do, HIDA, and liver function tests would make sense, because remember, if this backs up, the next organ that's going to be bothered is the liver. What do we do about this? Well, we want to give the gallbladder some rest to see if it can process these stones out on its own. So for that, we want low-fat foods. Remember, high-fat foods are likely to trigger the gallbladder into action, so we want to let it rest and relax and try and pass those stones on its own. So a low-fat diet will be helpful. Weight loss, because remember, the gallstones can be connected with obesity, and restriction of alcohol as well can help. We recommend spacing meals. This is someone, if they don't need to lose weight, if they need to still get some calories in, we could do frequent smaller meals. But if they need some caloric restriction to help with their obesity, it may be helpful to have fewer but smaller meals still as well. So we're triggering the gallbladder a little bit less, and we're not dropping a big bolus of food in at any time that's going to activate the gallbladder. We want to correct the bile obstruction. If there's something physically blocking the bile duct, removing that blockage however we need to will be the next obvious thing. That could look like a stent, or it could, even if there's a tumor pressing on the bile duct, we might want to remove the tumor. Whether that could be in the cancer setting, that's my background, is working in oncology. If it could be a curative treatment, that's great. But even if it's palliative, not for curative goal, palliative resection of a tumor to allow the bile to flow freely could be helpful and therapeutic for a patient. If the gallbladder needs to be removed, obviously this is a big step. We do something called a cholecystectomy. Once it's gone, you don't ever get it back. So we don't like to rush to this necessarily, though that is a pretty common procedure. In fact, one of the recent times I've taught this lecture, I had a student who had to undergo that, and it relieved her symptoms, though she had new symptoms kind of have to come to deal with too. We want all of our body parts, and they do important things for us, but if it's not working right, it may have to go. They very often do a laparoscopic cholecystectomy. That means they make a series of small incisions, which are nice because they don't have that big open incision, a series of smaller incisions, and then they use tubes and scopes and tools that are kind of long to fit through there to remove the gallbladder. And actually, a laparoscopic cholecystectomy is one of the most common surgeries performed. Following that, our concerns are the same concerns you would expect for any major abdominal surgery. Even if it's laparoscopic, it's still a major surgery. We're taking out a whole organ. We are concerned about the sites themselves healing like they're supposed to. We're looking out for hemorrhage. Now, that hemorrhage may not be visible outside of the body because remember, the gallbladder is within the body. It's in that abdominal cavity. So if it bleeds, especially with those little lap sites, it may be bleeding down into the abdomen or the peritoneum possibly. So we would look for vital sign changes. The first thing to expect if we're having a hemorrhage is hopefully we'd have an indicator with the pulse increasing and the blood pressure decreasing. If that gets too far, we get into shock, and I sure hope you don't miss symptoms of shock. But this can be an indicator early on. Maybe the first set of vitals they get after surgery, they're 120 over 80 with a pulse rate of 70 or something. And then you go check vital signs an hour or two later, and you notice they're 100 over 60 and their pulse is 90. That's trending in a direction that, while that may be within normal values, and your nurse aide consequently may not think to call you about that, you as the nurse are hopefully noticing that and saying, this is not going in the direction I want. Let me assess a little further. I'm going to check the abdomen to see if I can see any firmness developing. And I'm going to let the surgeon know, just so it's on their radar and we can get ahead of this earlier if we need to. We need other concerns, just getting over anesthesia. Early mobility can be helpful for these patients, any of those kind of surgeries. A lot of the time, the surgeon will order them to have their meals in the chair and not in the bed, so even dinner after that surgery could be reasonable to be in the chair instead of the bed. And when we discharge them, we need to give them careful education about the surgical complications and lifestyle changes they might have to make. They might have more urgency with their bowel movements following this too. I've heard that come up an awful lot because they're not processing fat. They're not getting the bile injected like it's supposed to be into the intestine, so it won't flow like normal. Complications of cholecystitis can also include a fistula. A fistula, not just the thing they use for dialysis. This is also something that can happen with an infection, an abscess especially, where one body part connects with another one. So that can cause leakage of the bile into other body parts where the bile is really not supposed to be. Remember that bile is part of a digestive process. So if it gets in the wrong place, it can actually try and cause some major irritation and almost like a self-digestion process. We could see peritonitis if that's leaking down into the peritoneum, or if an infection leaks out into the peritoneum. That's just an infection that gets in the peritoneum, and that can be very bad very quickly. So we want to be alert to signs of that, as well as pancreatitis, because remember, the gallbladder is very closely connected with the pancreas through that common bile duct. Moving forward on to hepatitis. What is hepatitis? When we think the hepa, we're thinking about liver, and the itis, inflammation or infection. So this is inflammation or infection of the liver. Most commonly, hepatitis is viral. It's kind of the alphabet soup of diseases. There's hepatitis A, B, C, D, and E. Hepatitis A and E are primarily transmitted through the oral fecal route. Grossly, we can see these ones come up in restaurants if the food preparation staff are not washing their hands like they're supposed to. And you go to the bathroom, you get stool, even if you don't see it, little stool particles on your hand. You go prepare food without washing it off, you can spread hepatitis that way. It's gross. Hepatitis B and C are transmitted through a parenteral route. That means not through this GI tract. These ones very often can come from blood exposure, blood-borne exposure, or sexual transmission, sharing needles as well with IV drug users. And then hepatitis D coexists with either B or C and is transmitted in the same ways. What does that look like? Hepatitis A typically has an acute onset, meaning it comes on quickly, whereas B, C, and D have a slower onset and may be more difficult to identify as a result of that. Hepatitis A has 4 phases. There's a viral replication phase where the virus is growing within the host, and that may not have any symptoms, followed by a prodromal phase characterized by nausea and fatigue. Notice those are not very specific symptoms. You've likely experienced those in the setting of a cold, so those might not even push someone to go to the doctor. Following that is what they call an icteric phase, and at that point we're seeing potentially jaundice and darkened urine. Hopefully those will send someone to the doctor. And then finally there's a convalescent phase. The jaundice starts to go away, the symptoms start to resolve. This can take on the order of 2 to 4 to 6 months, that ballpark, so it's kind of long. With chronic hepatitis B and C, patients are likely to be asymptomatic or have symptoms of chronic liver disease. Acute hepatitis B or C could also be asymptomatic, meaning it doesn't have any symptoms. If it does have symptoms, they can include fatigue, nausea, vomiting, poor appetite, right upper quadrant pain. Think about where most of your liver is. It's mostly in the right upper quadrant, and it kind of goes transverse over to the top of the left, but it's just the tip of it. The bulk of it's in the right upper quadrant. You can see dark urine and those same light colored stools like you may see with cholecystitis, because remember, the gallbladder, the bile comes from the liver to the gallbladder. So if the liver is not producing bile, we may still have those fat digestion issues. Hepatitis D sometimes causes massive destruction of liver cells, liver failure, and death. Hepatitis B and D become chronic in 2 to 10% of infected patients. It means it doesn't go away and they continue to have problems with it. The patient is then a constant carrier of the virus and they could still transmit it. How do we diagnose this? It's primarily through history and physical examination, as well as laboratory testing. So we want to talk to the patient. When did their symptoms start? Did they have any weird food exposure or anything to that effect that could guide us to hepatitis? And then the physical examination. What do they look like? Do you notice changes in the skin color, that yellowing that you could see across the body? You may have to turn the lights on in the room. If they're tired and maybe even in pain, they may want to be in a dark room, but that's going to affect our skin assessment. So if we need to turn the lights on, we can and should for a thorough assessment. Liver function tests are primarily, it's a blood test. They'll look for those markers. ALT, AST are pretty common, and those would be elevated in the case of liver failure. There are also some other serologic tests that can detect antibodies specific to hepatitis. More intrusive, invasive test is a liver biopsy could be done, where they'll typically stick a needle and take a sample of the liver to evaluate. You may also see abnormalities in white blood cell counts, platelets, albumin, and prothrombin time, and INR may be affected as well. Remember, a lot of our clotting factors come from the liver, so bleeding is a big concern as these patients' disease progresses. What do we do about it? Hepatitis A, remember it comes on acutely. We are typically able to encourage rest and strictly avoiding substances that are harmful to the liver. This is not the time to take Tylenol. A well-balanced diet can be helpful, and they may require something called immune globulin. Hepatitis B, there are some drug therapies we can use to decrease the viral load, and those patients may also get immune globulin. Then hepatitis C is typically treated with antiviral medications. As these diseases may progress, which is not a sure thing, but as they may progress, they could lead to cirrhosis. There are some other things that can lead to cirrhosis as well. Think about people who have alcohol dependency issues over a long time. The liver is what's affected. It metabolizes the alcohol, and it actually, one of the first steps after it starts to metabolize it turns it into something acetaldehyde, I think, and it sounds a lot like formaldehyde, and I understand they're chemically similar, but that's an actual poison. So every time you're drinking alcohol, you're getting poison as part of the metabolism process, which is an interesting fact to me. In this case, when we get to cirrhosis, if we remember our anatomy, the liver is an organ that to an extent can actually heal itself, which is very cool. Once we get past that, where it can no longer heal and it can't compensate for its amount of destruction, we get to this cirrhosis. If the damage is halted before too much liver tissue is damaged, the liver will regenerate. But if we get to late cirrhosis, it's considered irreversible. They can do liver transplants, which we'll talk about in a little bit. Just because we very often associate cirrhosis with alcoholic liver disease, it's not always from alcoholic liver disease. So be very careful when you care for these patients. Don't jump to conclusions. Don't let your biases affect your care of these patients. Even if it is alcoholic cirrhosis, alcoholism itself is a very serious disease. It's not as easy to get over as just quitting drinking sometimes. Less common causes of cirrhosis can be biliary cirrhosis. This would be if the bile ducts are blocked and they cause continued damage to the liver. Think about someone who maybe has this pain but has poor access to healthcare for whatever reason. Could be poor insurance, or even some people just don't want to go to the doctor, and I don't necessarily blame them. But if we don't control it, it can back up and cause chronic issues. And cardiac cirrhosis as a result of right-sided heart failure can lead to this as well. What will cirrhosis look like? Fatigue, weakness, those kind of make sense. The liver's not working right. We're not able to metabolize like we expect. We can also see headache, anorexia. In this case, we're not talking about the anorexia that you may see with those poor young women who see too many fashion models and things and get weird ideas about what they're supposed to look like in their head. In this case, we're talking about anorexia where we have no appetite for medical causes. Indigestion, abdominal pain, which makes sense because our liver lives in our abdomen, nausea, vomiting, pruritus, which is our fancy term for itching, because we're not excreting some of these waste products and they back up and can excrete themselves onto the skin. We can see very thin skin. We can see a lot of edema. Think dependent edema. We can also see ascites, which is a lot of fluid building on the abdomen. When these people are very sick, they will often look so large that they almost have pregnant bellies and they're stretched taut. They're yellow and the skin is tight. We actually have to go in and drain that through a paracentesis. And typically, if they develop that, they need regular paracentesis, where they have to be drained to pull that fluid off. They'll feel very comfortable, but then a few days later, it'll all reaccumulate and we'll need it again. Think about some of the complications of that ascites. It's a lot of fluid, sometimes liters of fluid that build up, and it's not just sitting in your belly, it's sitting in your belly pushing on your other organs. So dyspnea can be common with these patients, certainly shortness of breath. And we can see how that can affect some of these other symptoms as well. We can also see palmar erythema, that's redness of the palms. If we do, it should be blanching with pressure. That's where it turns white and then the color comes back to them again. We can also see varicose veins radiating from the umbilicus. Bleeding and bruising are pretty common. We see a deficiency in vitamin K, thrombin, and prothrombin. The whole clotting cascade is a little advanced for this lecture, but there's a lot of steps and a lot of them originate in the liver. So if that doesn't work right, our patients are more likely to bleed and bleed extensively. We can see the spleen enlarge, which may be palpable, but probably not at a nursing level. I'll leave that deep palpation for the physicians. Skin lesions, endocrine disorders, peripheral neuropathy. Urine may become dark and foamy. Stools may turn clay-colored, indicating bile's not reaching the intestine. Jaundice comes because the body's not able to process bilirubin. So we can see jaundice for causes other than cirrhosis, but they're all related to bilirubin not working like it's supposed to. Basically, waste products building up in our blood. Another scary complication is something called esophageal varices. So the portal vein carries a lot of nutrients back from the intestines and especially the liver. If the liver is all scarred and cirrhotic, the portal vein's not able to flow very well and it can back up. One of the first place it backs up tends to be the veins surrounding the esophagus. So in this case, what we can see are distended esophageal veins, similar to a hemorrhoid, just in a different part of that GI tract, that spread out, and they're prone to bleeding, and sometimes in very dramatic fashion. It may be lots of blood coming out through the mouth all at once. It's a very unpleasant situation. How we treat that, if we can get in there early and do an EGD, so a esophagogastroduodenoscopy, that's an endoscopic procedure where they put a tube down your throat. They can go in and sometimes band, where they put a band and block off the worrisome parts of the varices before they may rupture. But it's not always perfect. I can think of a patient that I cared for years ago. This was actually when I was in nursing school, come to think of it. They had an experience where we followed a patient from the emergency department through their whole hospitalization. He came in, the picture of cirrhosis, jaundice, ascites, esophageal varices. I chatted with him in the emergency department. They brought him for an EGD, and when they put him under anesthesia, I was able to watch the endoscopy procedure, and they did a lot of banding. But he was never able to clear the anesthesia, and I don't think he ever spoke to anyone again. He ended up passing away about 2 weeks after that. So there's a lot to it. Even something that seems straightforward like anesthesia is not a safe bet with these patients. Remember, in the case of those esophageal varices, if we start thinking about bleeding, they're also not clotting very well, so it's much more likely to be a very dramatic bleed. Things we want to be mindful if we know someone has esophageal varices is we want to be careful about foods that may rupture those. Think like eating tortilla chips, how sometimes those can get lodged in your mouth and cause a lot of discomfort. It's annoying when it happens to us who don't have these further complications, but if that food goes and ruptures one of these varices, it can result in very rapid bleeding in a very dramatic fashion. It's kind of a very hellish looking way to go. The things we can do about it, other than that EGD, is we can give vasopressors, like vasopressin, to lower portal pressure. We can do injection sclerotherapy or ligation of the bleeding vessels. Surgical intervention is only really an option once endoscopy has failed, because we really don't want to cut these people open any more than we have to. They're not going to stop bleeding very nicely. A beta blocker may also be given to reduce blood pressure, and we may give vitamin K to help resolve some of those clotting deficiencies. How do we diagnose cirrhosis in general? We'll very often do a liver biopsy, just like we talked about earlier with hepatitis. Liver function studies, the same as we discussed earlier. A CT and a liver scan, and we may do magnetic resonance, MRI, to look at those structures. How do we treat it? The best thing we can do to treat it is to stop further damage. Remember, with cirrhosis in general, if we stop the liver damage before it reaches a certain point, I understand it's around 60% of damage, the liver can actually build itself back again. But if we can't get that far, we want to restrict fluid and sodium intake. Think about the edema and the sodium intake. What follows salt? Water follows salt. And these patients will likely need diuretics to help pull that fluid off. And we've talked about the paracentesis. If they're building up those large ascites that are causing issues with other body functions like breathing, then we'll tap. It's a tap, basically, is what we'll call it, and we'll drain that fluid off. A cool thing we can do, not cool for patients. No, well, it is kind of cool for patients. They have, it's like a Plerex, like we'll use for a chest drain, but they'll use it for a paracentesis, a peritoneal drain, where they'll leave a catheter that dwells through the skin and lives under like a tegaderm dressing that we can go in a sterile procedure and access with this large vacuum canister to help drain some of that fluid off. That's a nursing level task. Once they have that drain placed, we can then connect it with that vacuum canister and pull some of that fluid off. You don't want to pull too much off at once, and it'll typically be specified in the order, drain up to a liter of fluid or something like that, and then stop, because we don't want to make too consequential of a fluid shift through this. But that's a cool opportunity we as nurses can do to help care for these patients. And if they're going to deal with this long term, they can actually take those home and complete those paracentesis at home without having to come in every couple days for another doctor's appointment. If someone is potentially has liver cancer and is having these symptoms as a result of that, the more time we can keep them out of the hospital, the better. Even if their ultimate prognosis is poor, I know if I had limited time, I'd rather be at home, not sitting in a doctor's office as much as possible. Other complications of cirrhosis is something called hepatic encephalopathy. So if you see that word out in the wild, hepatic, we're going back to the liver, so you have to connect that hepatic with the liver. Encephalopathy is very similar to other forms. Cephalus, think about the brain. Apathy, syndrome, a pathology related to it. How this manifests in liver failure is confusion, delirium, maybe even convulsions, flapping tremors, and ultimately possibly coma. What happens with hepatic encephalopathy is ammonia builds up in the body and backs up into the brain, causing big issues. We can also see something called fetor hepaticus, where the breath has a sweet fecal odor as liver failure progresses. What do we do about this extra ammonia? We administer lactulose. Lactulose will cause them to then poop out effectively the excess ammonia. It's nicest if we can give this in its kind of thick, sweet, sickly sweet syrup that a patient could just swallow, but it can also be given the rectal route, which may be necessary in a patient whose symptoms are so severe that they can't follow direction to take a syrup. I've had to do that before, and it was personally kind of traumatizing, but it helped that patient's symptoms be relieved, and he was able to be less confused while we were able to continue treating his condition. In the case of liver failure, if we get to the point where it won't grow back when it's too far damaged, our only real solution may be liver transplant. That is a major surgery, and those patients will have to have all the transplant concerns. They have to take medicines forever and will always be somewhat immune compromised, but it can give them real lives following this, which is very cool. All right, that's actually working now. Liver transplants are most commonly for non-alcoholic cirrhosis, chronic active hepatitis, sclerosing cholangitis, metabolic disorders, and biliary atresia. Patients with alcoholic cirrhosis can still be eligible for liver transplants. A lot of the time, one of the caveats for that is they have to actually stop drinking. We don't want to use a useful liver on someone who's going to go and damage it again. So it's something to be mindful of, but be very sensitive for these patients. Don't make it a thing, and it won't be a thing for you. We need to embrace our patients as they come to us. We don't want to spend a lot of time lecturing them. 70 to 80% of liver transplant recipients will survive at least 3 years with good quality of life, which is pretty good for how big of a procedure it is. They're 73% at 5 years after transplant. What do we do following a liver transplant? We have all of the surgical precautions and surgical nursing care that we provide anyone else that's undergone a major surgery. We also have to administer immunosuppressants and watch how that new liver is working. Liver cancer. Gratefully, somewhat rare in the United States. It can be more common in Asia and Africa, where it's caused by a parasite called the liver fluke. There's a kind of mold that may trigger liver cancer as well, called aflatoxin. That's a mold that grows on spoiled peanuts, corn, and grains. Metastatic liver cancer is much more common, unfortunately, than primary liver cancer. The liver is supervascular and has lots of veins running through it. And as a result, it can be a common spot for cancer to spread and set up shop effectively. The two types of primary liver cancer are called a hepatoma, which comes from hepatocytes, and a cholangiocarcinoma, which is a bile duct cancer. Pathophysiologically, there's irritation and inflammation. With disruption of the structure of normal liver cells, the cancer then spreads throughout the organ, invades the portal vein and the lymphatic system, and commonly spreads to lungs, brain, kidneys, and spleen. It's an ugly cancer process. Though, as with all kinds of cancers, treatments are getting better all the time. What might liver cancer look like? They'll be very similar to a lot of our hepatitis symptoms, maybe right upper quadrant pain, fatigue, anorexia, weight loss, weakness or fever, and signs of poor liver function. Very similar to what we were talking about with hepatitis and early cirrhosis kind of stuff. The pain may radiate to the back. Because the symptoms are vague, often, diagnosis may occur late. Think, if you experienced pain, fatigue, a little bit of weight loss or weakness, is the first thing you're going to do run to the doctor? Not necessarily. Hopefully you'll bring it up at your annual physical, and hopefully the doctor will hear that and send you for more testing to try and manage this earlier if at all possible. CT or MRI are used to detect the presence of the tumor and the stage of the disease. Often we'll use PET scans as well to see what kind of spread might have happened as well. Those check for metabolic activity throughout the body and can be an indicator for cancer that's setting up shop in other body parts, metastases. We'll also very commonly do a fine needle biopsy or a brush biopsy during an ERCP, which we talked about earlier, to give a definitive diagnosis of some of these cancers as well. What do we do for liver cancer? As with many cancers, if we catch it early, we may be able to surgically resect it. That means open up a patient and cut out the cancerous part. If it's early stage and it's only affected a small part of the liver, that could be curative. You could cut out the piece of cancer, throw it in the trash, and go about your business. If it's too severe, we might have to take out more of the liver. We have to have a liver, so a liver transplant may be a viable option. They're not going to do that for someone who has metastatic disease because they don't want to give that liver to someone who's going to die anyways, unfortunately. It really won't extend their life either at that point. And then they'll have to deal with the post-surgical complications. But if they're able to get it when it's confined to the liver, a transplant can be curative. We can also do combined radiation and chemotherapy, tumor ablation, or laser or radiofrequency ablation, where we try and attack it with different methods. It's very cool. Kind of the science. It feels like science fiction. It feels like we live in the future, but some of our treatments are amazing. Next up, we're going to talk about the pancreas. Acute pancreatitis, as the name suggests, is an inflammation of the pancreas. We have pancreas and we have itis, pancreatitis. Itis always means an inflammation or an infection, and this one is convenient. It's not using a different term, it's the pancreas. It could be acute or chronic. Pancreatitis frequently accompanies obstruction of the pancreatic duct from gallstones or from the backflow of bile into the pancreatic duct. Most commonly, it's related to gallstones blocking the common bile duct. If you remember your anatomy, the gallbladder's up here, it feeds down in the bile duct, and the other side is the pancreas. And those join and then insert into the small intestines up around the duodenum, the next stop after the stomach, basically. So most commonly gallstones. Viral infections, trauma, an ERCP, that those procedures are not without risk. You're sticking a tube into a bile duct. Penetrating ulcers, alcohol, drug toxicities, metabolic disorders, scorpion stings, interestingly, depending on where you live, and a variety of other factors can also cause pancreatitis. Men tend to develop pancreatitis related to alcohol, and in women it's more commonly related to gallstones. You could see an abscess or pseudocysts develop. What's it going to look like? Well, think about where the pancreas is. We'll commonly see abdominal pain in the left upper quadrant. If you think anatomically, that's roughly where the pancreas is. Sitting and leaning forward may ease the pain. Think in a similar thing as some of our lung issues we can face, like the pleurisy and stuff. You take the pressure off of the inflamed tissue, that can ease some of the pain. The severity of the pain may also decrease after 24 hours. This is a pain that is typically made worse by eating. Remember, these organs are involved in digestive processes. So if you eat something, very often what you'll see is 30 minutes later, someone will be crippled over in pain. They'll still experience the sensation of hunger. Even if they know in their head that eating is going to increase the pain, they're still hungry. So sometimes they'll still try to eat. Then they'll feel awful following that. You can see nausea, vomiting, sweating, jaundice, tachycardia, and weakness accompanying this pain. They all kind of make sense. Those systems are all close, and this all sounds an awful lot like what we talked about with liver disease too, as well as the gallbladder disease. If we examine the abdomen, we will likely see tenderness in that area and probably guarding, where they're kind of trying to protect their abdomen. Lipase levels will remain elevated. We'll likely see hypoglycemia, hypocalcemia, and hypokalemia. What do we do about it? This patient we will keep NPO until nausea and pain are controlled. Remember, eating is going to make symptoms worse. So while we're resting the pancreas, we will not provide more food. We're going to manage pain. So we need to assess our pain and treat it appropriately. Because they're NPO, these are often parenteral pain medications, so through an IV route. They're often very strong pain medications. Morphine is pretty common. Dilaudid can be used as well. We need to eliminate alcohol. We need to hydrate, and often rapidly hydrate. We may have to provide pancreatic enzymes, so when they do start to eat, to replace the dysfunctional pancreatic enzymes so they can actually digest their food. And we want to look out if they have a cyst that may burst or something. We need to look out for signs of shock. A major nursing action is to be supportive of efforts to abstain from alcohol. Stopping alcohol is not as easy as just saying, I don't want to do this anymore. For some people it may be, but for many people this is a much bigger challenge than you realize if you haven't experienced it. So these patients need a lot of compassion, especially non-judgmental compassion. Remember, how do you feel when someone's lecturing you? I remember being lectured as a teenager, and I just tuned it right out. So you don't want to be the person who's going on womp, 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 womp. You want to be someone who actually hears your patient concerns and is approachable and relatable, and they can hear your advice. Cancer of the pancreas. Unfortunately, pancreatic cancer is often detected late. If it's detected early, it's very treatable, but it often doesn't make noticeable symptoms until it's spread to other organs, at which stage mortality is very poor. The cause is unknown. It is more common in men and occurs in people over 55. It's also more common in African Americans. There is a big connection with cigarette smoking, as well as obesity and dietary factors, and diabetes, cirrhosis, and chronic pancreatitis as well are connected with this. Tumor in the head of the pancreas obstructs biliary and pancreatic flow, whereas cancer in the body and tail of the pancreas usually remains asymptomatic until it's very advanced and has invaded the liver and starts causing some of those other systemic issues. What can it look like if we do have signs and symptoms? epigastric pain. So around that area is going to hurt. Weight loss, very common with this. Anorexia and vomiting. Remember, with pancreatitis, pain was associated with eating. The same thing with pancreatic cancer if it gets severe enough. Early stage, you might not see this. Later stage, especially, when they eat, they'll often 30 minutes later, once the pancreas is ready to engage, they'll be in 10 out of 10, the worst pain you can see. I've treated this before and it's awful. You can see jaundice, dark urine, clay-colored stools. Sounds familiar, right? You could see a dislike for red meat and gluten intolerance. Think if it's not agreeable with their stomach because they can't produce the enzymes or it's not functioning right, that could be an earlier sign too. We can see more clotting happening. How do we diagnose this? Ultrasound. There's a lot of imaging we can do as well. The same CT scans, MRIs, and PET scans can be helpful, as well as a needle biopsy. We may also, some of the kinds of cancers may have an elevated CEA level. That's a carcinoembryonic antigen level that we see with some kinds of cancers. What can we do about it? The biggest part of our job as nurses is to help keep our patients as comfortable as we can. Unfortunately, a high percentage of patients with pancreatic cancer will die from it for those causes, the reasons we talked about before. It's typically diagnosed very late, unfortunately. It's one of those that can be a blessing if someone's in a car wreck and gets more extensive imaging and they find it as kind of an incidental finding. And they're able to treat it earlier. So it's one of those weird times where a worse accident or issue can actually be a good thing for these patients. We can do something called a Whipple. That's a surgical treatment, which is a radical pancreaticoduodenectomy. I struggle with some of these big words sometimes. It's okay. Pancreaticoduodenectomy, and does not have a great 5-year survival rate in the pancreatic cancer setting, but it's a fairly common procedure. Surgery is used mainly to relieve symptoms of obstructive jaundice, severe pain, and other complications. They can do some ablative therapies, and also radiation and chemotherapy are very common with this to try and slow down the cancer as much as possible. So these disorders in general, as we discussed, often present subtly and progress silently. Nurses play a key role in detection, education, and supportive care. Thank you for joining this episode of Sleepy Nursing. May your rest be restorative and your learning gentle. Until next time, breathe deep and sleep well.